We have a very special guest in the building. We're going to start off the weekend right. And more specifically, we're going to start off the weekend with an informative conversation. If you are just joining us, we have Dr. Anthony Ndiritu in the building, who's an oncologist who's here to talk to us about demystifying breast cancer. And I'm actually really excited to have this conversation. Welcome. Thank you so much for being here.
Thank you.
It's good to have you here. I hope you found the place okay.
Yeah, very nice.
Fantastic. So we have, I think the reason we've wanted to have this conversation is because it is something that I think a lot of people are very unaware of. I think there's a lot of mystery around breast cancer and just cancer as a whole. So it's an honor to have you here to kind of help us navigate this territory a little bit and shed some light on this conversation. So firstly, I guess before we begin, please tell us who you are. For those of us that don't know you, please tell us who you are and just tell us a little bit about your story.
Okay. My name is Dr. Anthony Ndiritu. What you call a clinical and radiation oncologist.
Right.
Clinical and radiation oncologist means I'm a specialist in cancer diagnosis, cancer treatment.
Right.
Mm-hmm. And in terms of cancer treatment, we employ different modes of treatment. That includes chemotherapy,
yes,
radiotherapy, what we call immunotherapy, what we call hormonal therapy.
Right.
So there are different modes of treatment that we do, and that is what I've specialized in.
Right.
The only thing I will not do is surgery. Surgery is done by the surgeons.
Right.
Then after that, the patient is transited to us.
Right. I see. Fantastic.
And how long have you been doing this?
I joined cancer treatment department. I started off at Kenyatta National Hospital, and I joined the department in the year 2005. So from that time up to now, I've been in that department. I did my specialization in South Africa.
Oh wow!
That is where I trained in medical oncology and radiation oncology. And all along, I've practiced in Kenyatta National Hospital.
Right.
I also have a practice that is called Kilimani Cancer Center, where we specialize in treating cancer patients. And we offer them all sorts of, all modes of treatment, that is chemotherapy, radiotherapy, and the other modes I've said. We also give them what we call comprehensive cancer care, that is supportive treatment, palliative care, cancer screening, cancer diagnosis.
Yeah. Before we get into that care, there's something I want to ask. This month is a breast cancer awareness month.
Yes.
And many of us, when we talk about breast cancer awareness month, we think it's more of a disease for the women, a disease for the girls. So today's conversation, we want to demystify that. You as a doctor, have you had experience where you've seen both men and women contracting breast cancer?
Yeah, cancer of the breast is affects both sexes. It is more common in females, but it also affects men. The main thing to think about, although it's more common in females, is that men who get affected tend to get more aggressive disease.
Oh, okay.
Not the breast cancer itself?
Breast cancer.
Okay.
It affects men, and it tends to be more aggressive than what you find in females.
Right.
And the other thing is they tend to get more advanced disease. Remember, for the men, their breast is not very formed like for females.
Yes.
So they have a very scanty breast tissue.
Right.
So when the cancer sets in and they don't go for checkup, it can invade the
other
organs very, very easily because it is closely attached to the chest wall.
Right.
So it will go to the chest wall and spread to other areas very fast.
Right.
But also the biology of the cancer, it tends to be more aggressive.
Right. So I guess for those that don't know much about cancer, I mean, we all know what cancer is, but we may not know it on the level that obviously you do because you've studied this, you've dedicated your life to this, especially when it comes to how it forms and how it spreads. Are you able to give us just a quick synopsis of how cancer actually works and how it actually spreads?
Yeah, it's a very important question to think about what is cancer. And in a simplified way, I would say cancer is abnormal growth of cells.
Okay.
And what happens is that these cells defy the body mechanisms of controlling growth. Remember, the rest of your body does not grow endlessly. It has some controls. So what these cancer cells do, they defy that. And what happens is that over time, it does not develop in one day. It is what we call mutations in the cells.
Right.
So the cells gradually become abnormal over a long time. We call it a multi-step kind of process. So that one gene is mutated today. After several years, another one is mutated. Finally, they become abnormal, and then they adopt these properties or these capabilities that now they are not obeying the normal control of the cells. And when that happens, they multiply very fast.
Right.
And they are not controlled. So they multiply endlessly. So what they do is once they do that, they have other capabilities that they are able to invade tissues. Remember, your normal cells are not invading tissues.
Yes.
They're just growing at a certain rate. Once they invade other tissues, then they are able to encroach into the blood vessels, and they can be carried to other organs.
Other parts of the body.
Through the blood vessels. Then apart from that, there is another mechanism of spread. When they invade the surrounding tissues, if you have an organ and the neighboring organ is closely opposed to that one, cells can migrate to the next nearby organ and they start growing in the next organ.
Right.
There are also other vessels in the body that we call the lymphatic system.
Lymphatic system.
The lymphatic system is the system that goes to what we call the lymph nodes, the ones you find everywhere in the body, what we simply call glands. It can spread those through the lymphatic system to go to other parts of the body. And once the cell gets there, remember, it is not obeying the rules in the body. So it starts multiplying there, and you get what we call metastasis.
Right.
And when this stage reaches, this is what we say now, this is not curable.
I see.
And the aim of treatment or the goal of your treatment is what we call palliative treatment, because now you're not curing it, you're aiming at probably prolonging the patient's life and
or maintaining
or
their health,
improving their quality of life.
Right. Right.
And when we reach that particular stage where that it's like, let me call it a point of no return. Is that, I don't know if that makes sense, where we are not able to sort that situation. What's your lifespan? I'm trying to look for a very good word, but how long does the patient have?
There is no definite time period. Remember, different cancers grow at different rates. The biologies of cancers are very different. You can diagnose some patients with advanced cancer and they live for many years. For example, if you diagnose a patient with prostate cancer, it grows very slowly and they may live for a long time even with advanced cancer.
Right.
Some cancers, they are very aggressive. If you talk about cancer of the lung, that is a very aggressive cancer. So you'll find they may not have a longer survival than others. Breast cancer, you'll find some of them have very aggressive disease, others, their disease is a bit slower. So it depends on what cancer you're talking about. So you may have a person even with breast cancer which has already spread. And with proper, what we calling palliative care, with all the methods that we use, chemotherapy, radiotherapy, and all that, you find they prolong their life even for several years.
Right.
At what point do they get, is it during palliative care, do people instructed that they need to chop off one of their breasts? Because I have heard of people, and I have friends and family who have gone into, that has been the mode of advice, like, you know what, to get this cancer out, we have to cut off one side. Is it because it's aggressive, or is it because that is the only way or the best way for it to be prevented?
Chopping off the breast, and I think now we are coming to the management of breast cancer. There are many ways of treating cancer of the breast. Once you have diagnosed the cancer of the breast through the various methods that we do, the next thing we want to do is what we call staging. Staging is where you want to find out how far has this cancer gone?
Right.
How big is the tumor in the breast? Has it gone to the lymph nodes that we talked about? Has it gone to other organs? It's like the liver, the lungs, and all that, the bones, the brain. It can go to all those areas.
Right.
If it has not spread, the best chance of cure is when you're able to remove the whole tumor.
Right.
If it is not very advanced, let's say it is what we call stage 1 and stage 2, sometimes we don't have to remove the whole breast. If the tumor is not very big, you may be able to remove the whole tumor and conserving the breast. We call it breast conservation surgery.
Right, right.
So like a portion of it?
Yes.
Okay.
You remove the tumor, but you want to remove it with a margin of normal tissue, so that you're sure you have removed the whole tumor.
Right.
But after that, you still need to give additional treatment to make sure that those microscopic cells that you could have left behind are cleared. And that is where you now add on to chemotherapy and radiotherapy and the other treatments, as we have said, immunotherapy and hormonal therapy. There are times you may find the tumor is very huge and the surgeon may not be able to remove the whole of it. Sometimes we give chemotherapy before the surgery.
Right.
And the aim there is to shrink the tumor so that you give the surgeon a better chance of removing the whole of it. And thereafter, you can now give the additional treatments to clear the cancer that has been left behind.
Right.
The other, if you are not able to do that, then you can give chemotherapy, but remove the whole breast if the tumor is quite extensive in the breast. But remember, we are talking of cancer that has not spread to other areas.
Yes.
So at that point, even when you're removing the whole breast, you're actually treating the patient for cure.
I see.
You're trying to cure the patient. So the best chance of cure is when you're able to do clean surgery where you remove all the cancer cells, give additional treatment to clear any residual cells that are remaining behind. So the patients you see getting the removal of the breast, what we call mastectomy,
Yes.
they are patients you are aiming to treat to cure.
Okay.
It's only that probably you're not able to conserve the breast.
Right.
And then after that, give them additional treatment to be able to clear anything that is there.
Right. I see. Well, if you are just joining us, we're having a very honest and open conversation with Dr. Anthony Ndiritu, who is an oncologist at the Kilimani Cancer Center. And I'm really excited for us to have this conversation because I think one of the things that I have come to learn is that breast cancer is something that affects both men and women. That was a big surprise for me. And I'm so excited to get into this conversation. We are going to take a quick break, but as soon as we get back, we're going to sink our teeth more into this conversation so that we can enlighten and educate each other right here on SpiceFM with the adults in the room. Do not go anywhere. Also want to have open and educative information that is spread to the masses. So that's why today we have a very special guest. We have Dr. Anthony Ndiritu, who is an oncologist, who's here to help us demystify some of the ideals or perceptions that we have around cancer, but more specifically breast cancer. And I'm really, really excited to get into this conversation. So I do have a question for you that I've been thinking about. I think when I think about getting regular screenings or getting regular health checks, a lot of the time I think about, just your regular blood test to make sure everything's running okay. But it's, at least for me, I find that it's rare that I think about needing to get like a cancer screening. If this is actually the case, why is it that you think people, I guess, don't consider it as something that they should do frequently? Because at least from what I've seen, and I've had some people in my family and even in like just my networks who have gone through this process of dealing with and battling with cancer. Why is it that people kind of leave it until there's a problem before they actually go and get a screening done?
What you find in our setup or in our communities is that sometimes people tend to leave things until the last minute.
Yes. Right.
You notice something, but you hope it is not what you're thinking.
Right.
And you leave it until either somebody else notices or it is giving you some pain or it is causing you some discomfort. Then you have it checked. The other thing is that in some areas, education has not reached everyone. And here I'm talking about health education, awareness. Awareness is very key in terms of encouraging people to go for checkups.
Right.
The other thing is when people go for checkup, they think about the blood tests you're talking about. And sometimes it doesn't really screen for anything much.
Right.
It's just routine. Sometimes you'll find somebody has a medical cover that gives him that facility. And they're happy to say that I usually go for my annual checkup. But you should be able to visit an oncologist and ask, what are the tests that I may need that would point towards the cancers that we are talking about.
Right.
The other thing, not all cancers can be screened. But what happens is that you get something in your body that you notice that is not normal or it is not your usual, and then you have it checked. The other thing is that sometimes you go for your routine checks and doctor may find something in the blood test that may suggest there could be something else going on, and they send you for further tests.
I see.
Yeah, but largely is the awareness has not been that good. But over the last about 5 to 10 years, there has been a lot of talk about cancer, which we are happy with, and I think the government gave a lot of prominence on cancer.
Yes.
And that has encouraged people to be aware. And so awareness is the key thing.
I see.
Yeah.
Yeah.
But when you go for checkup, there are some particular tests that we recommend. But also, if you have a family history, there's your checkups are more frequent than somebody who does not have a family history. Like if you're a lady and there is breast cancer in the family, your screening is more frequent than somebody in the general population.
Right. Yeah. So is that to suggest that genetics can actually play a role in either the likelihood or the frequency of something like cancer occurring?
Yeah, that is true. That is true. There is a good proportion of cancers that are genetic, that run in the family. They comprise about 5 to 10% of all cancers.
Okay.
They're actually genetic, and you find them running in families. But what we say is that if we have said 5 to 10%, we are talking about 90% which are not genetic, and probably they are cancers that you may be able to prevent if you look at the factors that cause cancers.
Right.
Dr. When you're talking about issues about awareness, yes, awareness has grown, but we're in a society where many of us tend to fear to go to the doctor because you're very scared of what will happen. As you say, most of us do the last minute approach. Now, I don't know if this is a myth, and that's why I want to ask this question. It is rumored that in ladies, there are certain hormones that actually are very cancerous, or some of us actually carry, and they have the potential to grow in us. Is that true?
I think to answer that question, I would want us to go towards breast cancer.
Okay.
Yes.
And breast cancer, you'll find, if we may talk about what causes breast cancer, we can divide them into broadly into 3 categories. There is the hormonal factors.
Yes.
There is the environmental factors, and then there is the lifestyle. And when we talk about, let me start from lifestyle. Lifestyle, we are talking of what we talk about: a healthy diet, avoid smoking, that is limit your alcohol intake, maintaining a healthy body weight, regular exercise.
Even weight.
Yes. Avoiding fatty diets, avoiding processed foods, processed meats. Those are the environmental things that is the lifestyle, that predispose you to those cancers. The other thing in terms of environmental, there are those things that we talk about, pollution and all that. There is ladies probably who had been treated with radiation previously for other cancers, like the cancers of the blood that we call lymphomas. Sometimes they get radiotherapy to the chest area, and the growing breast gets cells mutating, and later on in life, they get cancers of the breast.
So I was treating something, and in the process
Yes.
of treatment has caused
Yes.
a cancer cells in me.
Yes, and it's a broad category that we call secondary malignancies that result from previous treatment.
Yes.
See.
The other one now, if I may go to hormonal,
Yes.
and that is actually where your question was. The hormones we are talking about are the female hormones, what we call mainly the estrogen. There is estrogen and progesterone.
Yes.
So the estrogen, you find those factors that cause prolonged exposure to high levels of estrogen predispose you to cancer of the breast. And here, what are those factors? We are talking about ladies who got their menses very early in life, maybe 12 years, 10 years. It means they have had a long duration too with high levels of hormones.
Right.
Ladies who don't breastfeed, you get a baby and you don't breastfeed. Ladies who have never got a child, that is also a risk factor for breast cancer.
Really?
Those who get their first child later in life, maybe above 35 years, they have an increased chance of getting breast cancer. Those ladies who get to menopause much later in life, meaning their reproductive period has been very prolonged, meaning a longer exposure to the estrogen.
Yes.
Right.
They are at a higher risk of getting breast cancer. There is what we call, ladies, when they reach menopause, because of the symptoms of menopause, they may get what we call hormone therapy.
Yes.
Right.
Yeah? Hormone replacement therapy.
Yeah.
Hormone replacement, what is being replaced is the estrogen.
I
So it
see.
means it is beyond menopause. You're giving them hormones for a longer period to get rid of the symptoms.
I see.
Contraceptives. Long use of contraceptives. Those contraceptives are hormonal.
Yes. Right.
Yeah, those are factors that increase the chances. So you can see that category of people I've talked about. It is because of the high exposure of estrogen. So your question is actually true that it's a big cause of cancer of the breast.
I'm actually very surprised that estrogen plays such a fundamental role in increasing the likelihood of potentially going through cancer. Is there a reason behind that? And I know we're about to take a break, so maybe we can save this question for when we actually come back. But I'd be very curious to understand just some of in layman's terms, because some of us are not medical professionals, but in layman's terms, how the correlation between the production of estrogen can influence the likelihood of getting cancer. I think that's a very interesting concept that I'd like for us to get into. If you are just joining us, we are the adults in the room, and like I said, we're having a very informative conversation, and there's a reason we're having this conversation, which we'll get into as the show goes on, because it is important to be mindful of how important it is to get regular screenings. And Daktari will divulge that information as the show goes on. So I promise you do not want to go anywhere. We're going to take a quick break, but when we get back, we're also going to be sampling some of your views as the show goes on, because I'm sure a lot of you will have questions around the demystification of breast cancer. We have clinical and radiation oncologist Dr. Anthony Ndiritu in the studio to answer your questions. And of course, as we cross into the next hour, we're going to open up our phone lines, which will give you an opportunity to call in and actually ask him questions personally. Do not go anywhere. We are the adults in the room. Encourage you to tell everyone to make sure that they're getting their regular screenings. And the reason I'm saying this is because we have Dr. Anthony Ndiritu, who is a clinical and radiation oncologist in the studio with us, who's here to demystify breast cancer, a conversation that is very vital for our society and our population, because a lot of us don't even realize that we need to get regular screenings. So before we went on the break, I'd asked the doctor to essentially explain to us what the correlation is between the production of estrogen, or estrogen as a hormone, and how it can influence the growth of cancer cells. Are you able to just divulge that a little bit for us?
When you look at the body comprises of cells. And there's those we may call just general cells, but there are those that are specialized. So if you look at different tissues, the way the liver is, the cells are different from the cells of the stomach, the cells of the brain, the cells of the lung, and all that. The body works by messages sent from the brain, and then the different cells are stimulated to produce some chemicals that influence how the cells behave, be it the production of other hormones, being production of the digestive juices that you have in the stomach, be it the hormones that are produced to influence the rest of the body. Remember, estrogen is the one which gives the ladies the characteristics in a female. That is the growth of breasts. The body structure is different from men. Also, remember, they play a lot of role in maturation of the eggs and all that. All this about hormones. But what happens in different cells is that they have some proteins on the wall of the cell. Just to simplify that. For a chemical to be able to give a message to a cell to do something, it has to attach somewhere on the cell. That protein is what we call receptors.
Right.
So there are different types of receptors for different kind of chemicals, so that if they don't have the receptors, then the cell cannot be given that message to do something.
Right.
So specifically to talk about estrogen, some cells, some cancer cells or some body cells have receptors for estrogen, meaning the estrogen is produced in the body for the function that it has.
Yes.
But it has to come and attach to the receptor to be able to influence that cell, or to give the cell that command. Please do this. Please multiply. Please, or produce this kind of chemical.
Right.
So what happens? These breast cancer cells, some of them have the estrogen receptors or the progesterone receptors, but others don't. What happens is that the ones that have the estrogen receptors, they are very sensitive to these hormones, to the estrogen hormone, because it is able to come attached and influence how the cell behaves. And that becomes very important, especially when you're coming to do your treatment. You remember I said we also specialize in hormonal treatment.
Yes.
The hormonal treatment that we do is for those cancers that are sensitive to the hormones, to the estrogen hormone. So what we give them is medicines that block those receptors, so that the circulating estrogen has nowhere to attach to influence that cell to multiply.
Is that what people call the receptor status?
Yes, the receptor status.
Okay.
So when you get what we call a biopsy, or a tissue that is examined to confirm that there is cancer, or when your breast or the cancer is removed, it is taken to the laboratory. And the pathologist will tell us this is the type of cancer you have. And then we've said for another test, we call it immunohistochemistry. And that is what we call the test for the receptors. So they'll give us a report like estrogen receptor positive or estrogen receptor negative.
Right.
Progesterone receptor positive, progesterone receptor negative.
Right.
There is also another receptor that we call HER2.
The HER2.
Yes, it can be positive or negative. So that means if your cancer cells have that receptor, then if we don't give you that drug to block the sites, what we call the receptors, then it means the estrogen can influence. Remember, the estrogen is circulating in your body, so it can influence the cells to continue dividing, and that causes the risk of the cancer to recur. So there are two types of treatment that we do, either to block the receptors or to reduce the production of the estrogen in the body.
So there's less to actually influence.
So there is less
To influence mutation.
I see.
To reduce the production of estrogen in your body.
Yeah.
So that there is less estrogen circulating, so the cells are not getting stimulated to divide.
I see.
And this is more only because of the breast cancer, the cancer that we're talking about today.
It
cuts across different cancers?
No, that is mainly for breast cancer, the estrogen receptor and progesterone receptor. But when you come to the cancer of the prostate, we have what we call the progesterone. No, not testosterone, the male hormone. So when you have cancer of the prostate, we also give you hormonal treatment that acts on the production of the testosterone, because the testosterone is the one which influences the development of the cancer of the prostate and the multiplication.
Right.
So one of the main treatments for cancer of the prostate is the hormonal treatment.
I see.
Yeah.
I see. Wow. So I guess when you actually think about the process of going through a breast cancer screening, because today we're talking more specifically about breast cancer, what does that process actually entail? Because I know you've spoken about different types of treatments, but before you even get to a point where where you're going through treatment, what does the actual process of the screening entail?
When we talk about screening, we need to differentiate it from somebody who has a lump. That is, you have taken the lump to the hospital to be examined. That is not screening. That is now diagnosis.
Or examining.
Screening. What is screening? Screening means it is a healthy person with no symptoms or nothing found in the body, but you have gone for a checkup. Meaning you are apparently normal. You have nothing abnormal in you. You have not felt any lump.
Just walked into a clinic.
It's a checkup. Just a checkup. You want to be screened. So you have nothing abnormal in your body.
Right.
That is different from somebody who has found a lump and has gone to the hospital. That one is not going for screening.
Yes.
He's going for investigation of that lump.
Right.
Now, when we come to screening, we like going a step behind. We like, first of all, creating awareness for people to, first of all, have their own, to be aware of their body. We call it being aware of your breasts. Being aware of your breast is that you need to look at them regularly. whether it's in the bathroom, whether it's when you're dressing up, because that is when you'll notice this breast has become larger than the other.
Yes.
Right.
Or this breast it has some color changes than the other one.
Yes.
Or this breast seems to have some visible blood vessels.
Yes.
Or this breast is having some discharge. Or as you feel the breast, you feel there is some swelling or some lump that you have felt that you have not been feeling. But you only need to do that regularly for you to notice something that is new. So that is what we call being aware of your breasts. And that entails also we teach you how to examine yourself at home, so that you know how to you can examine very often, but if you're doing it wrong, you might never discover something that is growing there.
That's true.
And when we talk about being aware, we talk about you checking the whole breast and also checking the area of the armpits and the areas above your collarbone, because that is where the lymph node, the glands, are found. So sometimes you find ladies who have come to the hospital, and the first swelling they have noted is in the armpit, and there is nothing apparent in the breast.
Right.
Yes.
So that is awareness, being aware of your breast.
Can I ask, when you talk about us being aware, because on a normal occasion, a woman would have like a small lump. I don't call it a small lump, but there's always something hard among the breast cavity or the breast area. Now, should someone be very worried about that, or it depends on the size?
It doesn't depend on the size. If it is a swelling that you're feeling that is not normal,
Okay.
then it should be checked. The other thing and that's why we are encouraging you to be aware, is because your breasts have changes at different stages of the cycle, because hormones are different. There are times you may feel like the breast is lumpy or it's a bit tender. But if you know how your cycles go, you know this is normal.
Yes.
By the time you're getting to the end of the cycle, you find they have gone back to normal.
Yes.
So that is why we encourage that regular check. So it is not all swellings that are abnormal. But if you have not been examining, you'll never know whether it's a new swelling.
I see.
So let's go to the screening now. When we talk of screening, now remember this is an apparently healthy person. So you've gone to the hospital. I want to do breast screening.
Yes.
It is usually in 2 stages. There is remember I said being aware of what you do. What you do at home is called self-breast examination.
Yes.
That is not screening.
Yes.
It's only that you know your breast, you can tell something that is not normal, then you go to the hospital. Then there is what we call clinical breast examination. That is what is done by the health worker.
Yes.
The health worker will be able to examine your breast and feel if there is anything abnormal, then they are able to send you for further tests.
I see.
Then there is what we said, like what you said you said Australia.
Yes, Australia.
Yeah, they from the age of 50, they prompt people to go for screening, and that also happens in Europe and all that. They'll prompt you to do that. The test that we usually employ here is what we call a mammogram.
Yes.
That is the main screening test. It's a special X-ray that is done on the breast, and it will be able to show any lumps or any swellings, both in the breast and part of the armpit area. The other test is that remember, a mammogram is an X-ray. For the younger ladies, probably less than 35 or less than 40, we don't want to expose them to radiation every year. So them we may do what we call the ultrasound.
Yeah.
The ultrasound does not have radiation, or the MRI, which we'll be able to diagnose.
I'm so sorry to cut you off. We do have to take a quick break, but as soon as we get back, I'd love for us to get more into this. And if you don't mind, would you be willing to also just show us the process of actually doing a self-examination when we come back from the break? Just so for those that are unaware or unfamiliar with that process, we can at least have some tips and tricks on how to actually start this self-examination. And this is the best time to jump on our live stream, www.spicefm.co.ke. Click on the visual stream, and this will give you an opportunity to chime right into the studio so you can also partake in this self-examination. Do not go anywhere. We are the adults in the room. Today we have clinical and radiation oncologist Dr. Anthony Ndiritu, who's in the studio with us to demystify breast cancer. And I'm so glad that we're having this conversation because, like we started off the show by saying, a lot of us don't consider getting screenings frequently enough until we find ourselves in a position where we might have a problem or we detect a lump. So I want to encourage you to pay attention, pay close attention specifically, because there's some very valuable information that is being shared. Now, before we went on the break, you were telling us about screening and some of the processes, how that process looks like. Please continue if you don't mind.
Yes, thank you. I had reached about, I had talked about the self-breast examination.
Yes.
Then I talked about the clinical breast examination. That is what you get from the hospital. That is what you get from your healthcare provider. And then I talked about the mammogram. Mammogram is the main screening test. But I said the young ladies, we use those modalities that don't produce radiation because their breasts are young, they're still growing, and you don't want to expose them to radiation when they are very young.
Right.
Even after 30, between mid-30, they're still young, they still grow?
They're still young. So we're talking of the other thing that we don't use the mammogram on them is that remember they are young, their breasts are a bit more dense than the other ladies. So what happens is that the test may not be as sensitive as for the older ladies. So there are various factors that make us choose whatever modality. Then once you have been able to find something, then you send it for further tests, biopsy and other investigations now to confirm if there is cancer. Then what is the stage, like what I had said earlier.
Right. I see. So in terms of the actual process of doing a self-examination, if you don't mind, are you able to either inform or maybe even if you're comfortable demonstrating what that process actually looks like and how a person should actually go through the process of doing a self-examination?
Yeah, I think we can from where I am, we can talk about it.
Yes.
And we encourage ladies to go so that they get to know what they need to do. One thing is that you should be able to expose your breasts properly so that you can see the whole chest. There are different ways you can examine when you're examining yourself. You can examine yourself while you're seated comfortably, upright, or you can be standing, preferably in front of a mirror. You can also be lying down, but when you're doing your examination, the best is either seated or standing. What the first thing you do is that you put your arms behind your head. Like that. That helps to stretch the muscles and expose the breast tissue. Then once you do that, if you're examining the left breast, you use the right hand. If you're examining the right, you use the left.
Well, the other hand is still on the head.
Yes, because you want it there so that
to stretch.
expose the breast properly. So what you do is that the first thing is to check for the changes that we talked about. Changes in size, changes in shape, changes in color, the skin itself, the nipple area, and then press the nipple, see whether there is any discharge. Those are the main things you do.
If someone gets to see discharge, should they be alarmed?
Yes, if it is an abnormal discharge. If you are not lactating, then you should not get a discharge. Sometimes there may be a milky discharge, bloody discharge, or another color, maybe greenish and all that. That should be investigated further, even if you don't feel a lump. Then after checking, that is what we call inspection. Then you need to do the examination. So remember your arms, your hands are there.
Yes.
So if you come now to examine, let's start with the breast on this side. What we do is you divide it into 4 quarters. We call them quadrants. So you divide them like that. The purpose of that is so that you know that you have examined the whole breast. If you examine generally, you'll miss some areas that you will not know that you have missed. Then when you come to examine, you don't examine with the tip of your fingers. You examine on this part.
Sort of like
your fingerprint area.
The middle of the fingers
The
almost.
middle of the fingers here, not the tip. If you stretch your fingers like that, this is very sensitive to any lumps or anything abnormal on the breast. If you use the tips, you'll miss the lump.
I see.
So you use this part. With your hands, with your palm very straight. Like that. Remember, we have divided into 4 quarters.
Yes.
You can start with any quadrant. So you start there with that part of you, and then loud motions like that.
I see.
Pressing against the chest. You do that. Then you go to the next quadrant. When you're examining the outer quadrant, the breast extends towards the armpit. So make sure you go towards the armpit.
All the way up.
So that you don't miss the extension of the breast. Go to the other quadrant. Do the same. Soft motions but firm, so that you're like pressing against the chest. Then you go to the other one. Once you have examined the 4, go to the central area where the nipple is. Do the same. And then do that for the other breast. Divide into quarters, go 1 quarter by quarter until you're finished, and go to the central area. The other critical area I said is the armpit area. Go to the armpit, deep into the armpit. There are very many glands that are found there, from the front side, the back side, and deep inside. Make sure now there,
like the curve of the armpit.
Yes, inside the armpit. Press with your fingers. If you're going deep, you can use now the tip of your fingers to feel is there a swelling inside.
Right.
Then do the same for the other side, and then after that, above the collarbone, glands that are found there and along the neck.
Yes.
Once you do that, then you can be able to know whether there's something abnormal that you have, that you
You
find.
still use your fingertips on the collarbone?
Yes, because now there you're digging to what we'll call the supraclavicular fossa. A fossa is like a dip.
Yes,
So
that
you
little
want
indent.
to feel deep inside there and feel, is there a swelling? Is there a gland? Because that can point to something.
Yes.
If you find a lump in your armpit and there is nothing on the breast, then the breast needs to be examined, because it may only be originating from there or elsewhere. Then the
Right.
further test will be able to locate where that is coming from.
Right, I see. And I think it is very important that we take time to actually do this. How frequently does one need to actually engage in this process of doing a self-examination?
The self-breast examination should be as frequent as possible, because that is something you're doing every day.
Every day, yes.
It is not like visiting the doctor.
Yes.
You're with your breasts every day.
Yes.
So we need to make an effort to self-examine.
Make sure you check your breast at least once a week, so that you're able to check it regularly, and when you're comfortable, not when you're in a hurry, you're late for work.
Yes.
On Saturday, when you're not in a hurry, you're going to take a bath. Take your time and examine your breast when
I
you're
see.
comfortable, relaxed, and not in a hurry.
I see. Fantastic. Well, ladies and gentlemen, we're going to be opening up our lines, and this is your opportunity to ask our special guest in the building any questions that you have around this. If you've had, ideals or perceptions around what breast cancer might be like, and you're learning a thing or two, this will be your opportunity to call in and actually ask him those questions. And with his permission, I'm sure he'll be willing to answer any questions that you might have around this conversation, which is a very, very important one. The number to call is 0719 012 600. I'll say that number again, 0719 012 600. And I ask that as we answer these questions, that we get straight to the point, so we can ensure that we get as many people through the system and through the line as possible to ensure that we can answer your questions. Do not go anywhere. We are the Adults in the Room. Evening world, my name is Arnold, also known as the Bad Boy Sweetheart, and I'm in the studio with the Duchess of Ikolomani. And of course, we have a very, very special guest, an esteemed guest, Dr. Anthony Ndiritu, who's here, who's in fact a clinical and radiation oncologist, who's here to demystify some of the perceptions that we have around cancer, but more specifically breast cancer. And I want to hear from you. The number to call is 0719 012 600. But before we actually start answering calls, I'd love to see what the social handles are saying. What are you saying, Barbara?
We have someone on Twitter who's called Karugu Gakera, tuned in from Bassa, and the question they have is, 7 years ago, my wife, aged 48, had a hysterectomy, I hope I'm saying that correctly, due to a cervical cancer. For the last 1 year, at times, her breast become tender and they have a milky discharge. Please advise.
What would be your thoughts, doctor?
When was the hysterectomy?
7 years ago.
7 years ago.
Yes.
Yeah, that's a good question. Hysterectomy is what we call the removal of the uterus.
Yes.
It can be done in early cervical cancer. Sometimes they may remove the uterus together with the ovaries and the tubes, depending on the stage of the cancer. And if it was 7 years ago, then it means it was early cancer,
Yes.
if it had not recurred. But now she has talked about, is it a discharge?
Yes,
From the
this
breast.
is the husband
Yeah.
who's talked about for the last 1 year at times. So it's something the last 1 year they've seen. At times, her breasts become tender and have a milky white discharge.
That may not be related to the earlier treatment for the cervical cancer.
Yes.
And those are some of the signs that we said they need to have a check. So it is of concern if you are not lactating, if you are not breastfeeding, you should not be producing that milky kind of discharge. They need to still examine and see, is there a lump. But the fact that there is a discharge, although he didn't talk about the age of the lady.
48.
48.
Yes.
Yeah, if there is a discharge, that needs to be checked. But remember also, this is an age group that we have said they should be going for regular screening.
Yes.
So this is a lady who should actually be examined and also be taken through a mammogram.
Okay.
I understand. Yes.
Then we have another person called Waziri who says, I'm tuned in. Please ask the doctor, what are some of the foods that predisposes one to breast cancer?
We talked about healthy diets. Huh?
Yes.
Healthy diets, we are talking about diets rich in fruits, vegetables. You want to avoid processed meats. You want to avoid those refined sugars. The other thing
I'm even getting scared.
I know.
Yeah. One of the main things that we also talk about diet is diets full or rich in fat. That is one something that one should reduce on. But remember, we usually say that you can eat anything so long as you're taking in moderation. So long as you're not taking those refined foods, you ensuring you have a good portion of vegetables and fruits. The only thing to put a caveat on is smoking. We say that is a no. Alcohol intake, we say reduce to the minimum. Yeah, that is a major factor in causation of breast cancer.
When we started, you were talking about palliative care and other forms of treatment for breast cancer. I'd like to ask, what are the possible side effects to a person?
On treatment?
Yes.
If we may talk about the treatments, the three main treatments that we talked about. We talked about surgery, we talked about chemotherapy and radiotherapy. Yeah. If you talk about complications of surgery, we are thinking of those complications that can happen intraoperatively, that is in theatre, or immediately after theatre. Those are anesthetic complications, or bleeding, infection to the wound. Those are the main immediate ones. But if we come to chemotherapy, the main toxicity, they talk about nausea, vomiting, poor appetite, inability to eat. There is the hair loss, which is very common because of the drugs that we use for cancer. There are others which will affect other things, like they may affect your kidneys if you're not well hydrated. There are some which are toxic to the liver. There are some which will suppress your blood cells. Remember the white blood cells.
Is chemo really recommended? Because sometimes from just what I hear the public and what I've seen, someone goes for chemo and they become like more sick. I don't know if I'm making sense, but I always feel like it drains them more, and then they end up getting complications of, as you're saying, kidney. Now, is it something that is not for everyone, it's for just a selected few?
Remember, this is a clinical decision on who is fit for chemo. Remember, there are many things that we check for. But if you're being treated for early cancer or even late cancers, the doctor will evaluate you and know, can your systems be able to handle the chemotherapy. But when the doctor tells you they think you should get chemotherapy, it's beneficial. Remember, we said it is to clear the other cells that could have been left in the body. The chemo may be toxic in terms of the side effects that I've talked about, but there are medicines to take care of those side effects. The hair loss is something temporary. After you finish your chemo, the hair will still grow.
Depends on if you have good genes.
No, the hair will grow.
It always grow?
Yes, after the chemotherapy. The loss of hair is because of the mechanism of how the drugs work. They work on cells that divide very fast, like the cancer cells. Where your hair is formed, the cells are dividing very fast. So it suppresses that. So once you're out of chemo, your hair grows again.
I see.
Yeah. When you come to the radiotherapy, the main thing is maybe the changes on the skin. There is the lungs, which are just below there. There is the heart there. But with the techniques that we do, the new techniques, we are able to minimize the dosage of radiation that goes to those organs. So what I can advise is that treatment for cancer may look a bit toxic, but I can tell you that treatment works. And people should not fear the treatment. There are medicines to take care of the side effects that come with it.
Fantastic. Let's answer some calls. Hello, SpiceFM.
Hello.
Hi, sir. How are you?
I'm fine.
Fantastic. Please tell us your name and where you're calling from.
I'm Victor.
Victor.
Yeah.
Hi, Victor. How are you? I hope you're well.
Say hi to Barbara.
How are you, sir?
I'm fine.
What are your thoughts? Or do you have a question for the Daktari?
Okay. What you are talking about is about you have to be financially stable
Mm-hmm.
for you to undergo those screening.
Oh, Victor's disappeared. But I think I understood what the question that he was getting at. I think essentially what he was maybe trying to get at is this something that if you do find yourself having a positive diagnosis, is this something that can be quite costly, or how can one, I guess, navigate that territory?
Yeah, I think I heard what he was talking about, and I think he has brought us to a very important question about healthcare financing.
Yes.
Right.
Healthcare financing is quite a challenging problem, especially in our setting. Remember, the bigger proportion of Kenyans don't have health insurance.
Yes.
True.
These tests that we're talking about, they tend to be a bit expensive. Remember, even the national scheme, the NHIF, not everyone can afford it. Not
Yeah.
everyone has it.
Yes.
And then it also has limitations. It doesn't pay for everything.
Yes.
And that is where the challenges come in. So those tests, I can agree
Even
with him.
screening is not free in some places after this month.
Yeah, screening, you may have free screening, but the tests are expensive. The tests are expensive. Not everyone is able to afford. But what I would encourage, and even the treatment now is even more expensive. But what I would encourage, in case that is needed, if you go to the government hospitals, even if you can't afford, they are what we call social workers who will take you through and navigate you through, and they are what we call the waiver systems that that the government offers for those who can't afford.
Okay.
So that should not be a reason not to go to hospital for checkups and also for treatment.
Right. Because I can imagine that there'd be a lot of people who would say, I don't want to go and get a screening because if they find something, I don't have the money to be able to afford treatment anyway. But like you're saying, that shouldn't be an excuse to not know the status of your health.
True. And also, sometimes people think what I don't know does not
Won't hurt me.
But what I want to assure people, if there is something growing, it will still grow and
Right.
it will still come out and you will still notice it. But the problem, you might notice it when it is a bit too late.
I see. I see. So we have to be vigilant to ensure that we are at the very least understanding the status of our health. So I also understand that there are different types of breast cancer. I think from my knowledge, my little knowledge of cancer and breast cancer specifically, is that if we talk about breast cancer, we just talk about it uniformly. But from what I understand is that there's actually different types. And how do these different types of breast cancer differ?
When you talk about breast cancer, think about the structure of the breast. Mainly, if you look at the breast, it comprises of what we call ducts. Ducts are the tubes that carry the milk to the nipple too, for the baby to breastfeed.
Yes.
And there is what we call lobules, where the milk is produced. And then there is the nipple area. And then there is the supporting tissue. All these different tissues can develop cancer.
I see.
So when you get cancer developing in the ducts, or those tubes, we call it ductal carcinoma. Ductal cancer, ductal carcinoma. We may have one that has not gone beyond the duct, and we call it ductal carcinoma in situ. In situ means it has not gone beyond what we call the basement membrane of the duct.
Okay.
If the cancer now becomes what we call invasive, meaning it has now gone beyond the duct, now it has the capacity to invade other tissues and also to spread.
I see.
Then we have talked about the lobules, that is the glands where the milk is produced. It's a different type of cancer. It is called lobular cancer or lobular carcinoma of the breast. And you can have also what we call the lobular carcinoma in situ, which has not gone beyond the ducts. But remember, I've said all those other structures can develop cancer. You can have sarcomas of because of the other tissues that are there. There are muscles that are underlying there. But the main, the most common is what we have called invasive ductal carcinoma, the one which develops from the ducts. Yeah, that is the most common. The other thing is, in terms of characteristics of this cancer, is what we talked about, the molecular part of it, the biology of it, which ones are receptor positive. You know what you mentioned about those
Yes, I remember when I was
receptors.
talking about the receptors.
And that is important in terms of the aggressiveness of the cancers.
Yes.
And you'll find there are some that you'll treat with hormones, others you cannot. Also, the behavior of the cancers also depend on the age. You will find the younger ladies will tend to get more aggressive cancers than the older ones. Yeah. There are many factors that play in determining what type of cancer you're having.
When you're talking about ductal, that cancer,
carcinoma.
Yes.
Yeah. It reminded me of women who are lactating. For example, maybe I am lactating or I am a mother. Then I realize that I have gotten breast cancer. Even after treatment, do I still have hope that I could still breastfeed, or that is something that I should not think as an option?
Sometimes you can diagnose cancer when a mother is lactating, and
Yes.
probably they may sometimes they may think it's because the breasts are engorged and
Yeah.
all that, but sometimes you may find a lump. The other thing is, remember, sometimes we even diagnose mothers with cancer of the breast when they are pregnant.
Yes, yeah, I've heard of that.
Yes, and this when we are managing this kind of patients, we usually have to work as a team to get the best treatment for them, because we don't want the cancers to spread, but also we have a pregnancy to protect.
Of
Yes.
course,
We don't want the cancer to spread, but there is a baby here who needs to breastfeed. So if, depending on the stage of cancer that you have, there is not the stage at which the pregnancy is.
Yes.
There are some stages actually that we give chemotherapy when you're still pregnant, because there are some that, depending on the stage at which the growth of the baby is,
Yes.
they may not be affected by chemotherapy. There are things that we may not give, like radiotherapy, when you're pregnant.
Yes.
So we may delay that. Remember, surgery, you can still get surgery to the breast when you're pregnant.
I see.
And the baby can still be safe. But once we deliver you and you need to go through chemotherapy and all that, you cannot breastfeed when you're getting chemotherapy. And that is why when now you have to put the baby on formula and that kind of thing. So if we are able to delay your chemotherapy until you deliver, then we want to start you on chemotherapy, if that is where we are in terms of treatment, before the cancer spreads.
I see.
Yeah. But
When
the
we
baby
come
is
from
able
the
to feed
break,
on the
because you're
formula.
about to go to one, I want you to, I just want to ask, maybe from a layman's point, if there is a scenario like someone is expecting and they find out that she has cancer, is it transmitted to the baby? Or can it be transmitted to the baby?
Okay.
Yeah, I think I can answer that very quickly.
Yes.
Okay, sure.
That is not transmissible to the baby.
Oh, okay.
Yeah. If you have cancer, also the other thing people worry about, can I transmit it to my husband? Or
Yes.
if I have cancer, can I transmit it to my wife? That is not possible.
Okay.
Yeah. And also when you are on chemotherapy, it does not affect whoever you're with.
I see.
Because it is in circulation in your body.
Right.
So that's why we are saying the baby cannot breastfeed.
Yes.
Because it's circulating in your body. It will be it may be excreted in the milk.
I see. Makes sense. Well, if you have a question for our dear guest today, Dr. Anthony Ndiritu, please feel free to give us a call. I do see the calls coming in, and I will do my best to continue to allow him to give us insight, but also give you an opportunity to ask your question for today's conversation. Do not go anywhere. We are the adults in the room. Very special guest in the building. We have Dr. Anthony Ndiritu, who is a clinical and radiation oncologist, here to demystify breast cancer. So I hope that you, like I said, I hope you've got your drink sorted, you're somewhere comfortable, and you're taking notes, because it is one of the most informative shows and you do not want to miss. Now, before we get back into the actual conversation itself, let's see if we can answer some calls and see what people are saying. Hello, SpiceFM.
Hello, how are you?
Good, thank you. How are you?
I'm good. I have two questions.
Yes, please.
Dr. Harry.
Would you like to share your name, darling?
Okay, I'm Monica.
Monica, nice to meet you, Monica. Please feel free, ask your questions to the doctor.
Okay, first question is, for those having saggy breast, is that breast cancer related?
For those that have saggy breasts.
Yes, and my next question, when you talk of lumps,
You talk of?
how does that, lumps on the breast, how does that really need to feel? Because I personally felt some form of lumps, and And then when I went for checkup,
Mm-hmm.
I was told that it is normal breast filling. So I need you to expand on that.
Right. Okay. So I guess the question is, when actually detecting a lump, how do we know that this is actually something that
cancerous.
could be cancerous?
How old are you?
Yes. I'm 27.
27.
Yes.
Okay. Yeah, I think I got two questions from you. One is about sagging breasts.
Yeah.
Was that the question?
Yes.
And the other one is about the lumps. About sagging of the breast, that is not really a sign of cancer. But people have different types of breasts. There are some which are larger than others. There are some which could be sagging, but you could have normal breast tissue in any type of breast. What would be of concern is the lumps that you have talked about. You're a young lady. We'll find that most of the lumps that you find in young ladies actually are not cancerous, but we usually say in oncology that something is cancerous until proved otherwise. But that is for purposes of encouraging you to go for a checkup, because we don't want to miss cancerous lump among those 90% that are not cancerous.
I see.
So that is why we want every lump to be investigated. What you may need to do is what we call an ultrasound of the breast, and that will give the features of that lump. If it is a lump that really concerns you, the surgeon should be able to investigate it and either reassure you, or if it is of concern, the lump can be removed and examined by a pathologist. But the best thing is see a qualified surgeon to have a check on your breast, or see an oncologist. You can come to us, we can have a check, then we can advise you appropriately.
Fantastic. And I'm actually glad that you said that, because one of the great things about you being here today is that your clinic is offering consultations tomorrow. Are you able to talk a little bit about that for those that are listening?
Yeah, this month is Breast Cancer Awareness Month, and we give it a lot of importance. And the reason why we give breast cancer a lot of importance is because breast cancer is a leading cancer in Kenya and also globally. The other thing is that cancers are very the new cases of cancers generally that we diagnose in the country is about 42,000 every year.
Oh, wow.
And we have about 30,000 deaths every year from cancer.
Wow.
Now, when we talk about all the cancers that we diagnose, about 25% are breast cancers.
I see.
And that is why we give it that kind of prominence. So what we are doing is tomorrow we are checking, or rather we are offering us free screening for breast cancer. So anyone can come into our facility. We'll be able to examine you for free. If there are further tests, then we will be able to recommend and advise. The other thing, as we do that, we still also at the same time, we don't want to restrict it to women or to men just because of breast cancer. If you have something of concern that is related to cancer, we'll also be able to examine you for free. That is tomorrow, and then we'll give you appropriate advice.
I see.
Now that you're saying about where the examination and the screening would be, please share with us the exact location for someone who's listening.
For us, we are located at, it is called 40 Suits. 40 Suits is on Hospital Road, not far from Kenyatta National Hospital, opposite the Nairobi Club.
Ah, yes.
You come to 8th floor.
Oh, yeah. You've said it.
Once you're on 8th floor, you'll be able to locate us.
I see. Fantastic. So I want to switch gears a little bit, and I want to put a little bit more highlight on men specifically, because I think we were talking about this on the break, and I echoed to you that I was very unaware that breast cancer for men is actually a thing. And the question that I posed to you was, why is it that you think this isn't either prominent when we think about breast cancer, or why it is that maybe fewer men are actually going and getting checked up and having their screenings? Are you able to dissect that a little bit for us?
One of the reasons that you'll find men not going for screening, men have what we call a poor health-seeking behavior.
Okay.
They don't want to go to hospital.
Right.
Even when they are sick. Sometimes they have to be carried when now they can't walk. But we encourage them to go. The other thing is breast cancer is not as common in men as it is in women. So sometimes it gets not to be given a lot of prominence. But we try to encourage them because we see them in the hospitals, we treat them. And like I said, they tend to get more aggressive tumors. The other thing is that as much as we encourage them, sometimes we find the system does not create men-friendly clinics or facilities.
Okay.
Sometimes you know the nature of men. Sometimes they don't want to go to a clinic and sit among ladies, and they
7 ladies and you're the only man.
They
in the
feel
waiting
very
room.
uncomfortable.
Yes.
So what we encourage and what we try even in our facilities, sometimes when we're doing clinics, we try to bring men in one clinic so that they are comfortable, they are able to share with one another. You can imagine if you have prostate cancer with the kind of examinations we do, the kind of problems that you may experience, maybe erectile dysfunction and all that. And the only people you find in your clinic, on your clinic, they are women. You're not able to share.
Yes.
And that discourages men from going to the hospital. So what we try to encourage is make clinics that are more men-friendly.
I see.
Make screening programs
Or
that are
cleaning
more
days.
men-friendly.
Like the way we say Monday could be the day for pediatric, Tuesday nutrition. So you slot a
exactly.
day for men.
Exactly.
Okay.
Exactly. To
That's
encourage more.
That makes a lot of sense, because I think if clinics were able to offer such a service, it would mean that we would at least be able to see a higher rate of men being proactive and actually taking
But
the
do you
time.
have to be begged to go to hospital? Even men, you're finding.
But I do understand it though. A part of me does understand it. Being a man, I can understand being in a situation where you don't want to go to a clinic where you're the only man in a clinic full of women. So I do understand it. So I think I want to encourage men to be proactive and take your health seriously. If it means just going for a regular checkup, make sure that you actually set aside time to do this, because your health is important. And at the end of the day, especially if you have family, we all have family. Your family needs you. So it's important to actually be proactive in taking care of your health. As soon as we get back from this short break, our lines will continue to be open, and I want to hear more from you. We're also going to be sampling some of your views on our social media handles. And of course, we still have more questions to ask the doctor in the studio today, so that we can ensure that we are all informed and adequately prepared. Remember, there is a free screening tomorrow at the Kilimani Cancer Center, and it is something that if you've been meaning to do it, if you've been thinking about it, if it's been a while since you had a chance to get a screening, I want to encourage you to make sure that you attend tomorrow and get your free screening. We are the adults in the room. We are honored to have a very special guest in the building. He's a clinical and radiation oncologist who goes by the name of Dr. Anthony Ndiritu, who's here to demystify breast cancer. And if you've been listening, then you can tell that he's been giving us a lot of advice and a lot of insight into demystifying breast cancer. So I'd love to hear from you. 0719 012600 is the number to call. Hello, SpiceFM.
Hello.
Hi, how are you?
Good evening.
Please tell us your name and where you're calling from.
I'm Rebecca.
If you don't mind, are you able to speak a little bit louder just so we can hear you a bit clearer?
Rebecca.
Hi, Rebecca, darling.
Hi to Barbara.
Salama sana. What are your thoughts about the conversation, or do you have a question to daktari?
Yeah, mimi niko na swali kwa daktari.
Haya, bibu muulize.
Je, kuna dalili yoyote ya mtu weza kuwa ataona kuwa ako na breast cancer?
Rebecca, nataka upunguze. Rebecca, punguza sauti ya redio ama ya runinga ili tuweze kukupata vizuri.
Nimepunguza kila kitu.
Asante. Haya basi, endelea.
Nauliza. Je, kuna dalili yoyote mtu anayeona kama kuna breast cancer?
Kuna dalili yoyote mtu anaweza kuona
kama kuna hiyo breast cancer?
Kama kuna breast cancer.
Yeah.
Aya, alafu na swali nyingine.
Hiyo tu.
Aya, asante. She's asking, Doc, by the way, my brother doesn't know Swahili very well.
That's why I'm looking at her for translation.
She's asking if there are any signs or symptoms someone can notify by themselves, despite the breast examination, that she or he has breast cancer.
I see.
Answer in Swahili.
Yeah, mjibu na Kiswahili.
Hilo ni swali mzuri sana kwa sababu ndio inakufanya uende hospitali. Zile dalili unaweza pata za ugonjwa ya saratani ya kansa ya matiti ni unaweza pata kuna maji inatoka kwa sehemu ile ya mbele ya matiti ile inaitwa nipo. Unaweza ona maji inaweza kuwa inakaa kama maziwa, inaweza kuwa na marangi tofauti, inaweza kuwa greenish ama yellow. Ile ingine unaweza ukiguza matiti unaweza sikia kitu imefura kwa matiti, ama inaweza kuwa kitu iko na uchungu ama haina uchungu. Ile ingine unaangalia gozi ya matiti, unaona kama imebadilika ama kuna kidoda unaona, ama unaona kama iko na mashimo. Alafu ile ingine unaangalia ni kwa ile tunaita armpit, unafinya makwapa. Unafinya unasikia kama iko na kitu imefura ndani. Ukisikia kitu imefura ama ukiona hizo dalili nimesema kwa gozi ama kwa matiti yenyewe, unahitaji uende kwa hospitali ndio iangaliwe vizuri.
Rebecca, tuko sawa?
Oh, she's actually jumped off the line. But I'm hoping that she's been listening.
I don't need to translate. Doc had already said.
Yes.
But saratani is cancer.
Right.
Yes.
I see.
Yeah.
Right. Okay.
I can't tell you that, and I'm very sure that in Kenyan you know.
Yeah,
I know what that is.
Yes. So to further this conversation, we've spoken a little bit about not exposing people, particularly if you're quite young or still youthful, to too much radiation, because it can quite literally affect or speed up the process of the cells multiplying and mutating. So at what age should one actually start getting regular screenings? Is there like a beginning age, or is there like a minimum which it is safe to actually start the process of getting screenings?
Yeah, if you look at breast cancer and cancers in general, they tend to come in when with advancement in age.
Okay.
And that is why you'll find the longer people live, the more you find more cancers are diagnosed. Yeah. Breast cancer is in that category of cancers. It tends to come as ladies age. But having said that, you still find breast cancers that are diagnosed quite early, even in the late 20s, in the 30s. But the regular screening that we talk about, if you look at globally, you find in the Western countries, they tend to get their cancers a bit later than we are seeing in our country.
Yes.
You tend to see cancers coming from the age of 50, 55. And that is why you said, like in Australia or in Europe, they talk about screening from the age of 50. For us, we tend to start earlier, because we when we are saying this, we'll start from age 50, 55 there. Ours is from 35
I see.
to 50. You know, that is quite a young age.
Yes.
Screening, remember I said there are different ways you do screening. For the younger ladies, maybe below 40, you want to do the ultrasound. But if you find something, then you may do the biopsies and all that. So generally, we advocate for regular screening, at least from the age of 40. They can be able to do a mammogram. But the younger ladies, we do the ultrasound. Having said that, there are people that we screen more regularly than the general population.
Okay.
If you have a family history, if you have had other benign disorders of the breast, if you got a young family member, a lady, being diagnosed at an early age for cancer of the breast, then it means you need to be diagnosed early. Remember, we said there are some cancers that run in the family. There are some mutations that are usually tested in those cancers that run in the family. We call them BRCA mutations. Those who have been diagnosed with that, they should need to have regular more regular checkups. They may have mammograms even more regularly than they can be done even after 6 months.
Oh, so like twice a year.
Yes. Remember also, when you're doing screening, there are different changes that we see on the mammogram or on the ultrasound or on the MRI. And those changes are classified. And the way they are classified, there are those that you will see that you know these ones are completely benign and you do regular checkup maybe once a year. But if you find changes that are borderline, that they are tending towards cancer, those are people that you call in again for another test, maybe within 3 months to 6 months, just to be sure, until you're sure this is not cancerous. So the frequency of the screening depends on how high your risk factors are.
I see. So you mentioned benign cancers. You've spoken to us about how the process of cancer spreads and how the cells mutate. Just to shed some light on what a benign tumor might be, are you able to just explain that for us so that we understand the difference?
Yes. When we're talking of, let's call them tumors or growths. A tumor is any growth. When we talk benign, we are talking of not cancerous.
Okay.
And what differentiates cancer from benign? The opposite of benign is malignant. Malignant means cancerous. What differentiates is what I had said earlier, the characteristics of these cells. Are they able to invade other organs? Are they able to spread? How do they affect other organs when they spread? Benign tumors, they don't have, you have a growth there, but it can't invade other tissues.
Do I need to remove a benign tumor, for example, or a benign growth?
It depends on the purpose of that. Sometimes a benign tumor is removed to have it examined to confirm whether there is cancer. The other thing, there are people who will not want a lump in their breast. The other thing, it may be causing some pressure symptoms, but not invading anything else. Maybe it is disfiguring your breast or whatever organ the tumor is on. But if it is a harmless swelling and it is not causing cosmetic issues, it is not having pain, it is if it is confirmed to be benign, you don't have to have it removed.
I see. So I guess to add to this conversation, if someone was to receive a positive diagnosis, what are then, I mean, I know we've spoken about it really depends on the type of cancer it is and where it's located and how fast it's spreading, how aggressive it is. But what would then be the next steps for them following that initial positive diagnosis?
When you get a positive diagnosis will mean you have done a biopsy.
Yes.
And biopsy is tissue. Tissue has been removed from that swelling. We say for you to diagnose cancer, you don't use, the scans will not give you a diagnosis. So we say if there is no meat, then there is no cancer we have talked about.
I see.
So they have to get tissue from there.
That particular tissue that has a tumor or a growth?
That tumor, they have to get tissue from that tumor.
So you cannot do like a blood test and find out?
No.
Okay.
It has to be tissue. It has to be tissue from that tumor. That is what the pathologist looks at to say there is cancer. Even if I do whatever kind of scan, and I can see a swelling and it looks like cancer, I cannot even treat it until I get tissue from there and confirm that it's actually cancer.
I see.
So the pathologist has to look at the cells and say these are cancerous cells. So once that is done with the biopsy, remember biopsy is for diagnosis. Then the next thing is what we said, staging. Staging is trying to find out how far has this cancer gone. In the primary tissue, that is the breast, how big is it? Is it invading the skin? Is it invading the chest wall? Has it gone to the lymph nodes, the glands that we talked about in the various areas? Is it found there? Has it gone to other organs, the liver, the lungs, the brain? It can invade any other organ through the various methods of spread that we talked about. So the purpose of staging is to inform you on how you want to treat this cancer. So your goals of treatment are determined by the stage. So if the cancer is localized and it has not spread, then we are treating it for cure.
I see.
Localized is like it's in one area.
It is in the breast.
Okay.
We can say localized or locoregional. Locoregional means it is in the breast, and the lymph nodes that immediately drain the breast.
Okay.
Meaning that is cancer that can be removed in total and it gets cured.
Right.
If it has spread to other areas, then that becomes a bit more difficult to cure. But you have to determine your goals of treatment. You will treat it according to whatever symptoms the patient is having. You want to improve the quality of life of the patient. Maybe the patient is bleeding. Maybe the patient has pain. The other thing, you want to prolong life. If you reduce the disease burden in the body, you may prolong life. And like I said earlier, even to several years.
Yes.
So the next stage, I said, is now confirming the stage, and then you sit as a team, the surgeons, the pathologists, the radiologists, the other supportive services, to determine the best course of action. So that if you're giving chemotherapy first, you have planned with the surgeon, I'm giving chemotherapy from this duration to this duration, then I'll set the patient to you for surgery, then you set the patient back for radiotherapy.
I see.
All the other forms of treatment, as I said. So that is the journey of a cancer patient.
Fantastic. Well, we're going to take a quick break, but then we're going to come back and we're going to continue the conversation. There is still more of the show left, and I do not want you to go anywhere because it is going to be very informative, and we still have a few more questions. And before we end the show, the doctor will again inform you of what tomorrow is all about with the free screenings at the Kilimani Cancer Center. Do not go anywhere. We are the adults in the room. Conversation, and I hope that you have gotten a lot of value out of that. I can see we have a lot of messages on the social media handles. I've seen the calls coming through, but I wanted to create an opportunity for him to continue to impart his wisdom and his knowledge on us so that we can be better informed adults. There's a reason we're called adults in the room. So to continue this conversation, I heard that there may be a difference between I guess the process of detecting breast cancer in men and women, whether it's actually the actual detection process or whether it's the screening process. I heard that there might be some differences there. Is that actually true?
There is not much difference in it. The only difference is that the structure of the breast in a man is not like the women.
Yes.
So you may not be able to do a mammogram like we are doing on the ladies. But when you do the clinical examination and you find a lump, then you take it through the process of biopsy.
Right.
Then once you have got the biopsy and it has confirmed the cancer is there, then the staging investigations of the scans are basically the same.
Do they need to do the quadrant? The way you're telling us, you divide your chest area, if it's your man, to the quadrant, or because they don't have a flesh breast, so they just can do the whole mass?
Okay, men have a fresh breast, but
not all. Some are flat, daktari, some are flat, like camels.
They still need to do that. Remember, the reason why you want to do that is so that you're systematic in your examination, so that you don't miss any part of the breast. Remember, even for ladies, like we said, there are different structures of breast. There are some who have very little tissue in the breast, but they still need to follow the same system.
Procedure.
Okay.
I see. So I don't know if there's anything on the social media handles that we can chime in on before we wrap up the show. But if not, then we can give the doctor the floor to give him an opportunity to not only tell us about the clinic, but also tell us about tomorrow's free screening, and then also just an opportunity for you to promote yourself, Daktari. So please feel free to share any information or any knowledge that you wish to impart on our dear listeners.
It is very good that today we had the listeners. I can see they are listening, and that is actually our objective of being here.
Yes.
To create awareness, to encourage people to talk a lot about cancer. We want to encourage people to keep talking about cancer. What we usually say is that early checkup, early diagnosis saves lives.
Yes.
And that is our aim. We need to be aware of cancer, and I've given you the numbers, and you know what we are dealing with. In that breath, what we are trying to do is to encourage people to go for checkup. As a step ourselves from our facility, Kilimani Cancer Center, we want to offer free service, and that is free checkups, just to encourage people talk about breast, talk about cancer, get examined, encourage others. When you visit us, even if you don't bring a friend, we would want you to bring a friend. And even if you don't bring a friend, tell them what you learned there.
Yes.
Let them know those services are available. We are located at 40 Suits. 40 Suits is on Hospital Road, opposite the Nairobi Club, just on your way to Kenyatta National Hospital. We are located on the 8th floor. 8th floor of the building. Once you come there tomorrow, you'll be able to find us from 9 o'clock. We'll be there until we see the last patient.
Right.
The last client.
Yes.
Remember, these are not patients. I said it's screening. Screening
Right.
is for healthy individuals, but we also extend it to anyone with a concern about cancer. Can come to us, talk to us, and we'll be able to work with you.
Right.
Yeah.
So the clinic itself isn't just focused specifically on breast cancer, but all types of cancer, as I understand it.
Yes, we treat all types of cancers. We treat even children. Remember, children also get cancer.
Yes.
We treat all adults with cancer. The good thing is that we are comprehensive. We have supportive care, we have palliative care, we do cancer screening, we offer radiotherapy, chemotherapy, all the other types of therapy. We also do what we call home-based care. Home-based care is giving support to those that don't need to come to hospital, but they still need a lot of care. And we can do home visits for those ones. We also have counseling services. Remember, going through the journey of cancer requires a lot of support from family, from healthcare workers. You need somebody you're able to talk to.
Yes.
Somebody who can understand what you're going through, somebody who can help you navigate through. We offer those kind of comprehensive services.
Do you offer also services to the family?
Yes.
The counseling services, I mean.
That is what I'm talking about.
Okay, not only to the patient,
support
but
to
also
the families. Yes.
I see.
Okay.
I see. So I want to remind you, ladies and gentlemen, it is the Kilimani Cancer Center. If you have trouble finding it, I encourage you to jump online, go to Google and type it in. And again, I want to encourage you not to miss out on this opportunity. This is a chance for you to not only learn more about the state of your health, but to also encourage you to spread awareness. As the doctor has said, the best key to actually increasing awareness is having these free screenings and having conversations like this where we can actually inform and educate each other on exactly what this process looks like. And the more people that we can tell, the easier it will be and the earlier we can detect cancers before they get to a stage where they can be very, very detrimental. So I want to encourage you to wake up early, because I know, because we've been on radio and we've been talking about it, is going to be a very busy day for them there. And as he has said, from 9 a.m. until they see the last client, they're going to be offering these free screenings. So whatever it is that you're doing tomorrow, I want you to cancel it until you have gone in and you've had a chance to have this screening done. And remember, again, it is free, so you have no excuse not to go. If you want more information, go to kilimanicancercenter.co.ke. They have an opportunity. They have the contact details there. They have all the information that you will need to make sure that you're informed. And again, go there with a friend. Do not hesitate. Remember, your health is one of the most important things that you have to take care of. And I want to encourage you to tell everyone, make sure that you show up. I'm definitely going to be there. So if you're there, you might even see me there. And because I've realized that this is a thing for men. So from everybody here in the studio, we bid you good night and we shall see you tomorrow. Take care.
Good night, darlings.